I'm delighted to be here. It's really great to see so many people willing to come together on a Saturday morning. And I'm very tempted simply to say, well, I agree with her and I agree with you, and sit down. I mean, the issue is absolutely encapsulated in what Larissa and this bloke here, sorry, I don't know your name, but this chap here, for years, rare diseases have been seen as, rare, not very many people affected, not much you can do, probably not very important. But as Larissa has said, when you bring all the families together who are affected by rare diseases, then you have a huge problem. You have a big issue for those families who are affected, and you have a big issue for the health service. And when you think about it, the NHS in England spends about £120 billion a year. Of that, about £15 billion a year is spent on services and support which are almost entirely targeted at patients and families with rare diseases. But the challenge is to make sure that that £15 billion is spent in such a way as to deliver the best possible healthcare for those who need it in a timely, appropriate and user-friendly way. And at the moment, sadly, it's not. As we've heard from much of what Larissa has said, and also from the experiences of families which are very similar to yours, about rattling around the health service, spending time and energy trying to find someone who can help, someone who can say to you, I know what this is, and I know what we can do about it. We've just done a survey. We looked at the experiences of families with rare diseases and the sorts of issues that were affecting their lives. Now, for those of you who are parents or carers of patients with rare diseases, much of what I'm going to say is not going to be new to you. It will be telling you the things that you know already. But for those of you who are not, those of you who are professionals, those of you who are involved in the care and support, it's about putting the stuff that you do in the context of the lives of the families of those who are affected. And it's not just about the health service. It's not just about what medical professionals do. It's not just about what you can get from the hospital. It's about the expectation that you, just because you have a rare disease in your family, just because you're caring for a child or a loved one with a rare disease, you should have the same rights, the same expectations, the same opportunities, as far as possible, as any other member of society. And that's what we're trying to work towards. Now, of course, there is much that we can't yet do. Many rare diseases remain, at best, intractable. An awful lot of them are incurable. And as Larissa has said, many of them, sadly, are lethal, often in childhood, which is why research and the translation of new knowledge into improvements in service and support is so important. But what I want to do briefly just is to share with you some of the experiences of families about life with a rare disease and the way that their lives are affected in ways that are far beyond the medical costs, the medical interventions. And then to talk a little bit about the UK strategy for rare diseases and where that is going and what it might mean. Because, I mean, rare diseases, almost all, they're complex, they're multi-system disorders. They affect lots and lots and lots of different aspects of your life. They affect your opportunity to receive good quality medical care. I mean, Larissa's given you some examples, but I just want to quote, and one problem is that because individually rare diseases are rare, you know, every clinician, every doctor, whether he or she is a GP or a specialist in a hospital or a, you know, community paediatrician, every doctor will come across patients and families with rare diseases in the course of their career. What you don't know is which of the 8, 10, 12,000 rare diseases you're going to come across. And of course it's completely impossible for doctors to have this kind of you know, list of 12,000 rare diseases circling round in their head, and when you appear in front of them, to go, ah, right, I know what this is, I've seen it before, I'll spot it. If you're very lucky, they will. But what we need to try and create is a system where clinicians think, well, it's probably an unusual presentation of something common, because most things, you know, common diseases by definition are common. So I'll look for that, and if it's not that, then it's possibly something rare. I mean, what tends to happen in the health service is that, you know, you go round the loop again and again because people don't believe that their initial thought was the wrong thought. So they keep testing. There's some of the American HMOs, health maintenance organisations, have a mantra that says, do it twice, then do something different. You know, if you look at a patient and you think, I think I know what this is, I'll do a test, and it comes back wrong, then it may be that the test was wrong, so you do it again, and if it still comes back wrong, you know, don't keep banging your head on a brick wall, but think of doing something different. And to get a speedy diagnosis for a rare disease, we need to move clinicians into the do it twice, then do it different frame of mind. So, you know, I mean, for example, from a parent who said, I went probably in excess of 15 or 16 times. It's such a simple urine test for a metabolic condition that it could have been diagnosed in half of that time. And that would have changed things dramatically for my son, for my child. So, you know, think differently, think outside the box. And of course, with that delay in diagnosis, it means that opportunities are lost. You know, that if things could be done, they're not done, and potentially avoidable harms are allowed to happen because, you know, patients' children get worse than they need to because they miss out on that early intervention. And another patient said, I suppose the most difficult thing was it was such a long time waiting for a diagnosis. It felt the longest time, you know, and to be so unwell and so disabled after being so fit was very difficult because you don't know what's going to happen. You know, if you've got a disease that's well understood, if you've got a diagnosis, then you can find out what's going to happen and you can plan, you can access interventions. And this is something which families often report that clinicians don't seem to understand, you know, particularly those who are working outside of the expert centres like Birmingham Children's Hospital. Again, you know, parents said, I don't think professionals quite get it. They see you for half an hour at an appointment every 3 months, but they're not there, like last night when you have to get an ambulance and rush Henry into hospital. They're not there at that point. And the impact that that has on my 12-year-old, you know, it's not just the fact that you're coping with a sick child who may have a crisis that is poorly understood at your local district hospital, but the fact that you have other children, other family members, who see the alarm, the concern, you know, who see mum and dad looking anxious, going off in the middle of the night to hospital. It's that also has its impact. And then, of course, when you get to the hospital, do they know what to do? Do they know what they're dealing with? We had an incident a couple of years ago where he had an infection, and we really didn't feel confident with him being at our local hospital. We wanted to be so we felt like that we just weren't listened to. I think we spent more money phoning up the doctors at Great Ormond Street and going up and down to our local hospital and having to re-explain at every new sister and nurse that came on about Ben's condition. You know, it's that, as a parent, as a carer, you know, being the source of information. You know, when I go to the doctor, I expect the doctor to have expertise that will help me. I don't expect to be the resource for the continuing professional development of the doctor who's, you know, trying to treat me. And I'm not blaming doctors. Of course they can't be experts in everything, but, you know, we need to try and create systems and support so that, you know, when that little light comes on and says, I think this is a rare disease, there's somewhere where they can turn to get advice and support to take them to people like Larissa or Tim, wherever he is, you know, people who know, who have that expertise. But it's not just about that kind of time and energy that it takes. It's, you know, it costs a lot. It drains your income to have a child with a rare disease or a family member with a rare disease in ways that other families don't have to experience. You know, we've been seriously financially impacted. We have to go up the evening before. We have to fund everything ourselves, like the petrol, the food, sundries, subsidies, anything. Then we try and claim for it back, but we're down a day's money each month with my husband, who's self-employed, and then we have to find about 140, 150 pounds a month on top of everything else that we've got going on, and our usual hospital appointments. It's made a massive impact on our lives, and we've had to kind of reevaluate everything. So not only are you travelling, not only is your life disrupted, not only are you having to tell your boss that, yeah, I've got another hospital appointment, I'm not going to be in tomorrow because, you know, I've got to take little Jimmy to wherever. But, you know, you're paying for the privilege as well, and that shouldn't happen, you know. It's hard enough dealing with the issues without being impoverished by them as well, and we need to make sure that those costs, those direct costs, those financial costs are recognised and that families get supported. It's not just the financial costs. You know, it's the fact that you know, West Midlands is quite a compact area of the country. And families probably don't have to travel very far, although if they pick the wrong time of the day, they might take a long time to get to the hospital. But other parts of the country, you may have to travel for many miles and several hours. And if you've got a fragile family member, a child with a serious condition, or an adult who finds that physically and emotionally demanding, then, you know, that's another pressure. It's Sheffield for me is a good 40 minutes drive, plus a good half hour to find somewhere to park. How long did it take you to park? Those of you who came in the car this morning, you know, hospital car parking is, you know, can take you longer than getting to the hospital. And of course that's often results in a good many missed appointments because you can't leave the car. So there's no consideration of the impact that it has on the fact that he's missing large amounts of school, you know, going out for regular appointments, losing out on your schooling. I was talking to a mum the other day who's got 2 teenage boys with the same rare condition. She said, I forget the exact numbers, but in the course of a year she kept a track. She had something like 50 different appointments in 6 different hospitals in 5 different counties. And of course, picking up on your point, it would seem completely beyond the wit of the health service to make sure that each of her boys was seen for the same thing on the same day in the same hospital. So very often she'd be going to and fro twice for them. And, you know, these are lads, one of them's doing his GCSEs, the other one's just coming up to his A-levels. Imagine the disruption that is and the lost opportunity that represents. So, you know, we need to think about how we can better coordinate. You're absolutely right that, you know, it shouldn't be the case that you have to rattle around the service to seeing people. And the sort of models that Larissa is advocating for are, definitely the way forward. Doesn't necessarily have to be, a physical centre like the one they're building here in Birmingham. We could look at virtual centres. If you live in the West Country, you're going to be probably a very long way from any tertiary centre. But, we do have these, this thing called the internet. Has anyone heard of the internet? Technology. Yeah, video conferencing, remote diagnosis. We need to think imaginatively about how we can bring families and experts together without necessarily either of them having to spend large amounts of time stuck in traffic or waiting at train stations or flying from one end of the country to the other, in order that the expertise that is represented in tertiary centres like the Birmingham Rare Disease Centre, like Great Ormond Street, like Manchester, like Glasgow, and so on, can be accessible to patients and families wherever they live, right across the UK. And of course, this inefficiency, not a day goes by without there being something in the media about how stressed the health service budget is. It's about how there are going to have to be massive cuts to rise to the challenges that the health service is facing. And so, this was a healthcare consultant. It means that if we coordinate the care, it's more efficient, more effective, and there's not unnecessary duplication of attending multiple hospitals, multiple consultants effectively for the same problem. At Great Ormond Street. But the NHS, that's going to be less cost effective because there's less appointments missed, because people can't get the time off work, or they're driving around hospital car parks instead of seeing the experts who can help them. And above all, it neglects the emotional cost of uncertainty. The fact that as a parent, as a carer of someone with a rare disease, if you have a diagnosis, if you know what the problem is, you can begin to plan, you can begin to exercise a degree of control over your lives. You can think about what to expect in the future and anticipate and prepare for it. Whereas if you don't know, as one mum said to me not so very long ago, she has a child, an undiagnosed child, not been possible to find a diagnosis, and she says, every day I wake up, and the first thing that I ask myself is this the day that my child dies? Now that's not a situation that any of us would ever want to find ourselves in, but sadly it's all too common for families dealing with the consequences of a rare disease. And the effort that we put into planning and developing services must be, targeted to addressing those huge needs. So basically, what can we do about it? What can we do about it? In 2008, the European Commission published a communication on rare diseases that outlined what a national plan or strategy for rare diseases would look like. And in 2009, the Council of Ministers, the health ministers of the European Union, unanimously agreed on the Council of Ministers' recommendation, which called on all the member states of the European Union to develop plans or strategies for improving services and support for patients and families with rare diseases by 2013. The reason we have plans and strategies is because there's a certain, planning is what the French do, so it must be wrong. So the UK has a strategy. But the strategy was published in November 2013, and it's the first time that the 4 nations of the United Kingdom had come together. The health ministers of the 4 nations of the United Kingdom had come together to say, we must work together to improve services and support in a single comprehensive document. Elsewhere there's a cancer strategy. That's a cancer strategy for England. There's a cancer strategy for Wales, a cancer strategy for Scotland, and so on. But the rare disease strategy is unique in that it is a UK-wide strategy, and it recognises that in order to maximise the opportunity to help, in order to make best use of resources, in order to create the opportunity to do research, you need to have a critical mass of patients. And you're going to get a much better chance of creating that critical mass if you're talking about a population of 60-odd million rather than a smaller population. So we need to work on a UK-wide basis. And sadly, some of this has been put at, whatever your views about the European Union and whether as a nation we should be in or out of the European Union, from the point of view of rare diseases, it is undoubtedly we are better off being part of Europe than not being part of Europe. And one of the challenges that we face, given that Brexit is happening, is how we can preserve the opportunity to be part of a community which represents 450, 500 million people, rather than being separate and different on the edge. The strategy, the UK strategy, has got 51 commitments in it. And note that word, it's important, commitments. Not aspirations, not promises, not, around to it, we'll get around to it. 30 of those commitments are about delivering better healthcare and support to families. The other 20 are about improving the opportunity for rare disease research and development. And of course, because so many rare diseases are poorly understood, because there has been so little research into individual diseases, it is very difficult to do something about them. Which is why so many patients and families who have rare diseases are so keen to participate in research, even when they know that perhaps that research will be, perhaps of little direct benefit to them, but they hope that they will avoid the necessity for others to follow on in their footsteps, because there will be the disease can be spotted and something can be done. Now, in the UK strategy, there are 5 themes, and Larissa showed them earlier. They're empowerment. That's giving families the confidence to engage, to feel that they have understanding, that that their expertise, their insight into the management of their family member, their child with a rare disease, is recognised and acknowledged. The fact that you know more about dealing and supporting with, with your child, your loved one, than probably anybody else, makes you an important member of the team, alongside the clinicians and the nurses and the scientists and the industry and so on. The second theme is diagnosis. Without a diagnosis, you're in the dark. You don't know what to expect. You don't know, should you have another child? Will it happen again? Is there a risk? How long, what's going to happen next? The third theme is better coordination of care. We've talked about that, Larissa's talked about it, you've talked about the problems that you had. In the strategy, there is a commitment that every rare disease family will have a care coordinator. Now, I liken the care coordinator to a ringmaster in the circus. The ringmaster doesn't have to be able to, you know, make the audience laugh and tame the lions and walk the high wire. But the ringmaster has to know that the clowns come on after the lions and before the trapeze artist, you know, not the other way round. So that, you know, you can receive help and support, you can receive information in a logical way, in a way that makes sense, in a way that helps you to understand that if things should be done, you know, if, you know, at some point over the course of the next 12 months, your affected family member, your child or whatever, should have an MRI scan, it's not up to you to remember that, you know, that it's planned and it's brought in. That if you have to go into hospital, and when you come out of hospital, certain things need to happen. There needs to be care in the community support and so on, that it's ready for you, so you're not stuck in hospital while they get things together. And most importantly of all, that, you know, predictable events can be planned for. You know, you talk about your transition coordinator. I can tell you with absolute certainty that the date on which a child born today will achieve their 16th birthday and move from paediatric into adult services. Why is it such a surprise for the National Health Service? You know? Have they got sort of attention deficit disorder or something? It's, you know that at that point something's got to happen. So, you know, why leave it until the last minute? And I think the emergence of transition coordinators is going to be a hugely important step forward. And it will be cost effective, you know. And the fifth theme is research and development, because without research and development, you know, things will not move, things will change. Today's untreatable, incurable disease will remain tomorrow's untreatable and incurable disease. So we need to have that integration from basic research into clinical development, into therapy development, into licensing, into access, into, you know, and in a health service, in a clinical system that is prepared and able to introduce these new opportunities, these new ways of working, you know, because the infrastructure is there to deliver them, and the professionals have the skills to understand and to implement them. Larissa talked about, you know, consultants who say, well, you know, I can't possibly do that because it would mean changing my work plan. Well, that's not an acceptable answer. You know, of course the NHS is huge, is you know, like shifting the supertanker. It's got this massive inertia, but, you know, surely it can't be beyond the wit of humanity to think of ways in which you can, you know, begin to implement this new knowledge and deliver patient benefits. Now there has been progress, some progress, since the publication of the strategy in 2013. Scotland, Wales and Northern Ireland have got detailed implementation plans, and they've set up groups to oversee the implementation of the plans in those parts of the United Kingdom. It's been a bit slower in England. Unfortunately, NHS England got overtaken by its financial crisis, and the implementation in England took a dip. I mean, it was, you know, took a dip, it fell off a cliff. And it's only now beginning to get back onto track because, unfortunately, within NHS England, there is, I think, a culture of short-termism. You know, you solve today's problem by moving it to tomorrow. You don't have time to think strategically about, well, what would make a long-term difference that would allow to do things allow us to do things better. And you see that in terms of the time it takes for innovative therapies to go through the health technology evaluation at NICE, the commissioning process at NHS England, and the the implementation so that patients can benefit. And one of the things that we're trying to do, you know, Ben Howlett, the chair of the all-party group, is working with us very closely. We at Genetic Alliance UK support the work of the all-party group. One of the things that we're doing is to have an inquiry into access to innovative therapies in England through the NHS England commissioning process. Because at the moment, you know, the process is very obscure as to how it works. It's incredibly complicated with layer on layer of decision-making committees. And it seems, you know, that basically the job of, you start out with your ground level committee, and the ground level committee says, we think this is a good idea, we think you should do it. So the next level up says, well, that was naive, they probably missed something important. Let's see if we can find the fault in their argument and knock it back, rather than, well, yeah, that's a good idea, yeah. And the higher up you go, the more likely it is you get a no, because otherwise, what's your purpose? You know, if you're only there to rubber stamp what's gone before, then you're not doing your job, are you? Well, no, it shouldn't be like that. And there's no way in NHS England at the moment that you can have, you know, this is blindingly obvious, just do it. You know, it will save money, it will improve healthcare at no additional cost, you know. So we need to find a way of streamlining the bureaucracy. Of course, NHS England doesn't have unlimited money. There is no Department of Health sofa which you can rummage down the back of and find another 12 billion quid that you didn't know was there. Wish there was, but ain't gonna happen. So NHS England needs to be able to make rational decisions, but they need us to be part of that rational decision-making process. We need to understand what the calculation looks like. We need to understand what the elements in that calculation are, and how we can have a say about the weight that is attached to each of those elements, so that the decision-making process is fair, it's robust, and it takes account of the things that matter to us, as well as the things that cost the health service money. Right at this moment, there was a consultation launched by NICE earlier this week, which asks for your opinions as to what you think that process should look like. So again, if you go on the NICE website and look up consultations, you will see that their proposals about how they want to treat novel interventions for rare diseases in the future. So, you know, have your say, contribute to that conversation. So basically, what was it? You know, the future's bright, the future's orange. The future is, you know, brightening, I think. Rare diseases now are on the agenda in a way that they haven't been before. You know, a few years, I was to a meeting recently for the ABPI, the Association of the British Pharmaceutical Industry, where they got representatives of all the companies who are interested in developing therapies for rare disease patients. They had to move the meeting to a bigger room because there are so many companies interested in this area. A few years ago, you could probably have got the representatives of all the companies interested in rare diseases in a telephone box, and you probably still have had room for the buffet as well. So it's, you know, that there is a tide of interest that is swelling. You know, there are the Birmingham Centre, Great Ormond Street is building a huge new research centre, 80 million quid. There's developments in commissioning. But this is happening against the background of constrained resources in the NHS. So we, all of us, need to work together in order to remind our elected members, the commissioners in NHS England, you know, those responsible for planning and delivering services, those responsible for supporting the research in our universities and our medical schools, and those who are making decisions about how new medicines get through to patients, that rare diseases are not uncommon, and they are a huge consumer of healthcare resources. So, you know, it's in all of our interests to make sure that those resources are spent to the best possible effect. Which brings me back to Brexit. Brexit is going to potentially have a very serious impact on the opportunities for collaboration across Europe in the rare disease field. We were just beginning to see the emergence of expert reference networks, which are designed to bring together the experts in rare diseases from across the whole of the European Union. The UK had more proposals to lead ERMs and to participate, centres wanting to participate in ERMs, than any other member state in the European Union, because we are European leaders in this field. Unfortunately, in order to be a member of an ERM, you have to be in a member state. And we all know that Brexit means Brexit, whatever Brexit means, but it means we won't be a member state in a couple of years' time. We're already getting this kind of anecdotal evidence that collaboration that has been established is being put at some risk. So we need to work with our European colleagues to get them to tell their negotiators that they need us to be part of the network, as well as us telling our negotiators that we need to be part of these networks. We need to be able to collaborate with European research. So, you know, whatever else you think about leaving the European Union, for rare diseases, it is important that we try and maintain that collaboration. We keep the links, we keep the opportunities to build the critical mass, to do the research, to develop the interventions, to change the lives of those who currently live with intractable rare conditions. So, you know, that's your homework, and crack on.